I think there's been a strong interest in close to community health provision for a long time, growing out of the Alma Ata declaration, but there's been challenges to how they've been realised. And recently there's been a renewed interest in close to community providers as being key providers within the context of a human resource for health crisis, within the context of the push towards universal health coverage and the development of the post-MDG agenda. I think where the gaps are and where REACHOUT has been designed to help fill those gaps is the ability to learn across multiple contexts. What works well for close to community provision and why? And also to take a health systems approach that goes beyond looking at a single disease programme, for a focus on malaria, for example, and looking at how to develop lessons around strengthening close to community provision from a health systems perspective that builds on the voices and experiences of close to community providers themselves, communities and the diversity of communities, as well as key players and stakeholders within health systems. So the ability to learn across contexts and take a broader health systems view.
So to me it's about not just focusing on the individual, but thinking about the household, the community that that person comes from, the health services that are provided in that community and how they can be linked into the health system. It's also about understanding households at a glance, or because you know the community and the household. I think I was explaining before about what a unique opportunity we have when we go into people's homes as health professionals or as community outreach workers, because we can see and understand things that we can't see and understand when people get up, get dressed, walk to a health facility and then stand in a queue and then see us for 5 minutes. Those 5 minutes that we spend in a house seeing the environment, understanding whether people have bed nets or they don't, where they get their water from, how many people share a room, is instant information that helps us build an understanding of that person within the context in which they live, and that's a health context, but other contexts as well.
And to me, close to community providers are absolutely critical to people-centred health systems. And what came out from our qualitative analysis and the context analysis across the 6 REACHOUT contexts is how close to community providers are the visible face of the health system. They are and people talked about them as a bridge. They are a critical interface between communities and health systems. So they are absolutely paramount to people-centred health systems, and I don't think we know enough about their voices, their experiences, their lives, their struggles, their opportunities around juggling multiple workloads, about a lot of also our qualitative interviews show their deep passion and commitment to their communities. That's why they've become community-based health providers. And how hard is it if there's a really, really sick child, that family doesn't have the money to get them to a health facility? So we're seeing a lot of close to community providers hand in their own pocket to support health provision. So playing a pivotal interface role.
REACHOUT is a research consortium. We have 8 partners, and 6 of those partners are in Kenya, Ethiopia, Mozambique, Malawi, Indonesia and Bangladesh respectively. All of our partners have experience of working with close to community providers, and they all have close links to the Ministry of Health. Some are NGOs, some are research institutions, some do more policy work, but they all have that in common. And the 6 contexts that we work in all have established programs for community health workers. And one of the strengths of Reach Out is that partnership. Is this the background that people have brought to Reach Out, and as they share context, seeing differences and seeing similarities and working out how they can support each other and how we can support them in underpinning that with rigorous research.
And what's key to how Reach Out works in practice is enabling and supporting experience learning and sharing across contexts. And to me, one of the highlights for Reach Out to date was we've all been in Mozambique. We went on a field trip to visit a very rural community appiage, a community health worker in the Mozambican context, a woman who had the community had built for her a small health facility. It was incredibly rural, and so we had the whole Reach Out consortium there, people asking questions and understanding the particular challenges she faced. And our colleagues that work in urban slums in Dhaka, that context is so different, but saying we can learn across all different contexts. And there was a lot of debate and discussion around how to strengthen the particular supervision structures and strategies, and Reach Out working in practice is building on developing links and sharing experiences and good best practice across and between both diverse contexts and different health areas.
Reach Out has got 3 phases. So there's been a very in-depth context analysis that's taken over a year with multiple layers of qualitative research, of policy analysis and desk reviews and international review. And then it's followed by these 2 quality improvement cycles of a year, just over a year each. So the focus of each quality improvement cycle has come out of the context analysis, but in discussion with stakeholders, including the providers, the district staff, the policy makers and country advisory groups. So it's a feedback loop on the findings, presenting the results of the findings back to people and talking about what's feasible and what can work in this context, and then getting input from other partners as well.
And so that's why there's different foci in different countries. So it's being responsive to the emerging evidence and the priorities of different stakeholders.
And are there any particular key findings of the research you would like to highlight?
I think if there was one thing I would highlight is that there are similarities as much as contexts are very different. And the areas that have come up very clearly are around supervision, around coordination, and especially between multiple vertical programs, referral and community engagement. And each of those areas plays out in different ways in the different contexts, but there have been strong emerging themes. There's a lot of work that's gone on, and a lot of good work that's gone on. I think in terms of effectiveness, we do understand more about the effectiveness of using close to community providers. But the studies have been short. They don't have long follow-up periods, and they may focus on one particular programme or a project rather than focusing on a national scaled up system at community level. So we understand less about the larger scale, the sustainability, and less about areas like equity, areas like quality of services, efficiency. So we might be able to demonstrate effectiveness, but it's often in a small area with a small programme.
And I think one of the added values of Reach Out is the ability to generate evidence across multiple contexts, to allow inter-country analysis, and to look at similarities and differences across and between multiple contexts, and also to take the broader health systems approach that goes beyond a single disease focus and looks at a more broader building blocks health systems approach. So we can look at, you know, sometimes there might be unintended consequences. You invest in X, Y gets distorted. So trying to take a holistic view, I don't think there's been enough of that in the current evidence base, and that requires innovative multiple methods to capture that holistic health systems analysis and an ability to track changes through time. I also don't think there's enough evidence which is the voices and experiences of close to community providers themselves, their challenges, their opportunities, how they experience the ability or not to take forward and build equitable, people-centred health systems, because they are strategically placed to understand the challenges faced by different women, men, boys and girls, but to what extent do they have the power, the resources and the autonomy to really make change, and also to feed their experiences within health systems planning and priority setting. I think there's gaps there.
Reach Out is great fun, but part of why it's great fun is because it's a great privilege. We have really good researchers, we have partners that are working well together, and we have a topic that really we want to understand more about, and that enables those voices to come up and also to be heard in other contexts through the work that we're doing. So it is a great privilege to even just be involved or, you know, enable that to happen.
Within Reach Out we have a research update communication strategy which lays out our different audiences, our different strategies through which to engage with those audiences, and those audiences are many and they're also fluid and changing. And I think another key strength of Reach Out is the extent to which the partners are embedded within policy and practice within the different country contexts. So, for example, LVCT in Kenya, they are the secretariat for the Ministry of Health working group that's looking at, right now, how to change and improve community health worker services. Reach Trust in Malawi, very strong links also with Ministry, with technical working groups. Key players from Ministry, from practice, from professional associations are on the country-based community advisory groups. So that is a way in which to build ownership and bring multiple perspectives into the decisions around QI cycles. So what should we be focusing on? Where can we make adaptations to improve these services? And all the partners have those strategic links, and the more we can build on those and build ownership through the different QI cycles, the more we can see a lasting legacy of building quality multi-method research into strengthening services. And I think also key to policy and practice and dialogue and exchange is the focus on learning across and between contexts, and what we have as part of our capacity development strategy is South-South technical assistance, so the opportunity to learn from different contexts. How do they do supervision? How do they support referral? How, in this context, does coordination across a multiplicity of actors and providers happen? What adaptations can we make to bring that to our own context? And also key to our dialogue with different policymakers and practitioners is our thematic working group, which is endorsed and supported through Health Systems Global. And we have good buy-in and dialogue from USAID, from World Vision, from policymakers, implementers, from researchers. So that is providing a strategic opportunity to share experiences across and between contexts and to support dialogue with policymakers and practitioners. If you want to know more, have a look. You can contact Faye Moody at Liverpool School of Tropical Medicine.
Reach Out isn't going to be able to fill every research gap in this huge field. I would say there's an urgent need for more costing work. There is some within REACHOUT, but we need to understand that more in-depth costing work in different contexts and outside of REACHOUT contexts. We'd like to see more equity analyses. Equity is embedded within REACHOUT, but there are many additional equity analyses, particularly looking at the lived experiences of service users, so there's people who provide the services, of coverage, of gender. Some of those areas would be important to take the field forward.